Hello, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Chapter 60 Drugs for Asthma and Chronic Obstructive Pulmonary Disease. So, basic considerations. Asthma is a common chronic disorder that occurs in 1 in 11 children and 1 in 12 adults in the United States. Characteristic signs and symptoms are a sense of breathlessness and tightness in the chest, together with wheezing, dyspnea, and cough. The underlying cause is immune-mediated airway inflammation. In the United States, nearly 25.7 million people have the disease, representing an increase of almost 50% since the early 2000s. Each year, the disease kills about 3,500 Americans. However, despite the sobering statistics, the proper treatment, most patients can lead full lives with no limitations. Chronic obstructive pulmonary disease, or COPD, is a chronic, progressive, largely irreversible disorder characterized by airflow restrictions and inflammation. In most cases, COPD is preventable. The most common cause is smoking cigarettes. Symptoms include chronic cough, excessive sputum production, wheezing, dyspnea, and poor exercise tolerance. In the US, COPD affects about 24 million people. In the most recent report by the Center for Disease Control and Prevention, chronic lower respiratory disease were listed as the third leading cause of death in the United States. Unfortunately, although drug therapy is highly effective in asthma, benefits in COPD are minimal and limited to a small improvement in symptoms. Drug therapy does not slow disease progression, reduce hospitalizations, or prolong life. Please keep in mind COPD is chronic, it is progressive, so curability is not the focus. The pathophysiology of asthma, therefore. Asthma is a chronic inflammatory disorder of the airways in about 50% of children with asthma and in some adults. Airway inflammation results from an immune response to known allergens. In the remaining children and in most adults, the cause of airway inflammation is unknown, although as yet unidentified allergens are suspected. Figure 60.1 depicts the events that lead to inflammation and bronchoconstriction in patients whose asthma is caused by specific allergens. Although this model may not apply completely to all asthma patients, it nonetheless provides a basis for understanding the drugs used for treatment. The inflammatory process begins with binding of allergen molecules, your house dust mite, and feces, to the immunoglobulin E or IgE antibodies on mast cells. This causes mast cells to release an assortment of mediators, including histamine, leukotrienes, prostaglandins, and interleukins. These mediators have two effects. They act immediately to cause bronchoconstriction. In addition, they promote infiltration and activation of inflammatory cells, your eosinophils, your leukocytes, and macrophages. These inflammatory cells then release mediators of their own. The end result is airway inflammation, characterized by edema, mucus plugging, and smooth muscle hypertrophy, all of which obstruct airflow. In addition, inflammation produces a state of bronchial hyperreactivity. Because of this state, mild trigger factors such as cold air, exercise, and tobacco smoke are able to cause an intense bronchoconstriction. So if you're looking at this figure here, you see that allergen that attaches to the mast cell, which then causes the mediators, that histamine, the leukotrienes, the interleukins, the prostaglandins to cause that bronchospasm. That bronchospasm, has that limitation to airflow. At the same time, those mediators now trigger infiltration of inflammatory cells. Again, those eosinophils, the leukocytes, and macrophages, which therefore further activate mediators, your cytokines, your leukotrienes, your interleukins, and others, which trigger that inflammation. That inflammation, again, has that airflow limitation. That inflammation also causes that bronchial hyperreactivity, which again is triggered by cold air, exercise, tobacco smoke, other kind of pollutants, which causes that bronchospasm. So it causes kind of like that negative feedback system that further creates a bigger issue. The pathophysiology of chronic obstructive pulmonary disease, or COPD. Symptoms of COPD result largely from two pathologic processes: chronic bronchitis and emphysema. In most cases, both processes are caused by an exaggerated inflammatory reaction to cigarette smoking. Chronic bronchitis, defined by chronic cough and excessive sputum production, results from hypertrophy of mucus-secreting glands in the epithelium of the large airways. Emphysema is defined as an enlargement of the airspace within the bronchioles and alveoli brought on by the deterioration of the walls of these air spaces. Among individuals with COPD, the relative contribution of these two processes can vary. That is, some patients may suffer primarily from chronic bronchitis, some primarily from emphysema, and some from both disease processes. Figure 60.2 depicts the events that lead to inflammation, airway obstruction, and air trapping in patients with COPD. Irritants, such as tobacco smoke, initiate an inflammatory response in the airway. As a result of the frequent and recurrent irritation and the subsequent response by various leukocytes and inflammatory mediators, pathologic changes result in the bronchial edema and increase in mucus secretion that characterize chronic bronchitis. Additionally, the continuous inflammation inhibits the production of protease inhibitors, which have a protective role in maintaining alveolar integrity. As a result of these inhibitions, the protease enzymes break down elastin, resulting in the destruction of alveolar walls and the decrease in elastic recoil that characterize emphysema. In a small percentage of the population, emphysema results from a genetic alteration that results in alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is a protease inhibitor that protects the lungs from enzymatic destruction by proteases. So here is that figure that they were discussing just a moment ago, where again, your tobacco smoke and air pollution, your inherited alpha-1 antitrypsin deficiency, your systemic effects, your chronic bronchitis, your emphysema, all can cause that airway obstruction and air trapping. So if you're unfamiliar with the pathophysiology, it's a good spot to try and hit pause here. I'll try and make as much sense as possible there. Your overview of drugs for asthma and chronic obstructive pulmonary disease. The major drugs for asthma and COPD are shown in the following table. They fall into the two main pharmacologic classes: anti-inflammatory agents and bronchodilators. The principal anti-inflammatory drugs are the glucocorticoids. The principal bronchodilators are the beta-2 agonists. For chronic asthma and stable COPD, glucocorticoids are administered on a fixed schedule, almost always by inhalation. Your beta-2 agonists may be administered on a fixed schedule for long-term control or as needed to manage an acute attack. Like the glucocorticoids, beta-2 agonists are usually inhaled. So here is a prototype drug. Drugs for asthma and COPD, your anti-inflammatory drugs, your glucocorticoids. So you'll see that there is the beclomethasone and prednisone. And then your anti-inflammatory drugs, your cromolyn and cefiderocast. Your bronchodilators is your albuterol or salmeterol. Other bronchodilators, your theophylline, and your anticholinergic, ipratropium. The following table here is the overview of the major drugs for asthma and chronic obstructive pulmonary disease. Again, anti-inflammatory drugs, your glucocorticoids that are inhaled. It's a good spot to hit pause if you're unfamiliar with some of these or even all of them. And then there's also your inhaled, oral, and your leukotriene modifiers. And the list will keep going. Again, as mentioned previously, the cromolyn, your IgE antagonists, your phosphodiesterase 4 inhibitors, your bronchodilators, which include the beta 2 adrenergic agonists, your methylxanthines, your anticholinergics, your anti-inflammatory bronchodilator combo drugs, and the beta agonist cholinergic antagonist combo drugs. So I know I just went through like quick listing, so I'll scroll back to the top. Please hit pause. Make flashcards if you need help to remember some of these. It's always good to know the mechanism of action, how they work, where they work, major side effects, all things that we all know we will be quizzed on in the future. So hit pause, pause, pause when needed. So administering drugs via inhalation. Most anti-asthma drugs can be administered by inhalation. This route has three advantages. The first being therapeutic effects are enhanced by delivering drugs directly to their site of action. The second being the systemic effects are minimized. And third, the relief of acute attacks is relatively rapid. The three types of inhalation devices are usually employed via a metered dose inhaler, a dry powder inhaler, and nebulizers. Some pharmaceutical companies also have developed specialized inhaler devices for their products. So let's start off with the metered dose inhaler, also known as MDIs. MDIs are small handheld pressurized devices that deliver a measured dose of drug with each activation. Dosing is usually accomplished within one or two inhalations. When two inhalations are needed, an interval of at least 1 minute should separate the first inhalation from the second. Does that happen on a clinical basis? Absolutely not. Usually, most nurses will give one and then next breath, all right, here we go again. So, if you want to be a better practitioner, educate your patients to wait 1 minute. When using most MDIs, the patient must begin to inhale before activating the device. This requires hand-breath coordination, making MDIs difficult to use correctly. Accordingly, patients will need a demonstration as well as a written and verbal instruction. Even with optimal use, only about 10% of the dose truly reaches the lungs. About 80% affects the oropharynx and is swallowed, and the remaining 10% is left in the device or exhaled. Which brings us to spacers. Spacers are devices that are attached directly to the MDI to increase delivery of the drug to the lungs and decrease the deposition of drug on the oropharyngeal mucosa. Several kinds of spacers are available for the use of MDIs. Some spacers contain a one-way valve that activate on inhalation, obviating the need for good hand-breath coordination. Some spacers also contain an alarm vessel that sounds off when the inhalation is either too rapid, thus maximizing the effective drug administration. They can also prevent the bronchospasm that may occur with sudden intake of an inhaled drug. So here is two pictures, one with an inhaler that has no spacer and one with a spacer. Your dry powder inhalers, also known as DPIs, are used to deliver drugs in the form of a dry, micronized powder directly to the lungs. Unlike MDIs, DPIs are breath activated. As a result, DPIs don't require the hand-breath coordination needed with an MDI, and so DPIs are much easier to use. Compared with MDIs, DPIs deliver more drug to the about 20% of the total released versus the 10, and less to the oral pharynx. Also, spacers are not used with a DPI. Bringing us to nebulizers. A nebulizer is a small machine used to convert a drug solution into a mist. The droplets in the mist are much finer than those produced by inhalers, resulting in less drug deposit on the oral pharynx and increased delivery to the lung. Inhalation of the nebulized mist can be done through a face mask or through a mouthpiece held between the teeth. Because the mist produced by a nebulizer is inhaled with each breath, hand-breath coordination is not a concern. Nebulizers take several minutes to deliver the same amount of drug contained in one inhalation from an inhaler. But for some patients, a nebulizer may be more effective than an inhaler. Although nebulizers are usually used at home or in a clinic or a hospital, these devices, which weigh less than 10 pounds, are sufficiently portable for use in other locations. Your anti-inflammatory drugs. Anti-inflammatory drugs, especially inhaled glucocorticoids, are the foundation of asthma and COPD therapy. These drugs are taken daily for long-term control. Most people with asthma require these drugs for the management at some point. So your patients under care across the lifespan then, your anti-inflammatory agents. Children. Inhaled glucocorticoids are the preferred long-term treatment for children of all ages, including infants. A face mask is recommended for the administration of an inhaled glucocorticoid, and so that the children younger than 4 will receive the medication appropriately. Alternative treatments include cromolyn and leukotriene receptor antagonists, so that montelukast. But evidence supporting these drugs for asthma management is lower than that supporting inhaled glucocorticoid. Montelukast is the only leukotriene modifier approved for children ages 1 through 5. Pregnant women. Inhaled glucocorticoids are classified in the FDA pregnancy risk category C. However, they are preferred for uncontrolled asthma in pregnant women because uncontrolled asthma is associated with a greater fetal risk. Of the leukotriene modifiers, montelukast and cefiderlukast are pregnancy risk category B, whereas Silutin is a pregnancy risk category C. Breastfeeding women. Inhaled glucocorticoids are not a contraindication to breastfeeding. Women taking systemic glucocorticoids should not breastfeed. So, inhaler, okay, tablet, big no-no. Older adults, the benefit will exceed risk. Inhaled glucocorticoids are much safer than a systemic formula. So, speaking of glucocorticoids, that is your budesonide or fluticasone, which are the most effective drugs available for long-term control of airway inflammation. The administration is usually by inhalation, but may also be intravenous or oral. Adverse reactions to inhaled glucocorticoids are generally minor, as are reactions to systemic glucocorticoids taken acutely. However, when systemic glucocorticoids are used long-term, severe adverse effects are likely. The basic pharmacology of glucocorticoids is presented in Chapter 56. Discussion here is limited to their use in asthma. So, its mechanism of anti-asthma action. Glucocorticoids reduce asthma symptoms by suppressing inflammation. Specific anti-inflammatory effects include the following: decreased synthesis and the release of the inflammatory mediators, again, leukotrienes, histamine, prostaglandins. There is a decreased infiltration and activity of inflammatory cells, so your eosinophils and leukocytes. And then there's the decreased edema of the airway mucosa, secondary to a decrease in vascular permeability. By suppressing inflammation, glucocorticoids reduce bronchial hyperreactivity and decrease airway mucus production. There is also some evidence that glucocorticoids may increase the number of bronchial beta 2 receptors, as well as their responsiveness to beta 2 agonists. The use in asthma, therefore. Glucocorticoids are used for prophylaxis in managing chronic asthma. Therefore, dosing must be done on a fixed schedule and not as needed. Because beneficial effects develop slowly, these drugs cannot be used to abort an ongoing attack. Glucocorticoids do not alter the natural course of asthma, even when used in young children. However, they provide a significant long-term control and management of symptoms. The inhalation use, therefore, inhaled glucocorticoids are the first-line therapy for the management of inflammatory components of asthma. Most patients with a persistent asthma should use these drugs daily. An inhaled glucocorticoid is more effective and much safer than the use of a systemic glucocorticoid. Oral use, however. Oral glucocorticoids may be required for a patient with moderate to severe persistent asthma, or for management of acute exacerbations of asthma or COPD. Because of their potential for toxicity, these drugs are prescribed only when symptoms cannot be controlled with safer medications, meaning the inhaled glucocorticoid or an inhaled beta 2 agonist. Because the risk for toxicity increases with duration of use, treatment should be as brief as possible. Adverse effects. An inhaled glucocorticoid adverse effect. These preparations are largely devoid of serious toxicity. Even when used in high doses, the most serious concern is adrenal suppression. The most common adverse effects are oropharyngeal candidiasis and a dysphonia, meaning the hoarseness and speaking difficulty. Both effects result from the local deposition of inhaled glucocorticoids. To minimize these effects, patients should rinse their mouth with water and gargle after each administration. Using a spacer device can help too. If candidiasis develops, it can be treated with an antifungal drug. With long-term, high-dose therapy, some adrenal suppression may develop, although the degree of suppression is generally low. In contrast with prolonged use of oral glucocorticoids, adrenal suppression can be profound. Glucocorticoids can slow growth in children and adolescents, but these drugs do not decrease adult height. Short-term studies have shown that inhaled glucocorticoids slow growth. However, long-term studies indicate that adult height, although delayed, is not reduced. Less is known regarding whether glucocorticoids suppress growth and development of the brain, lungs, and other organs, in part because having asthma alone can affect organ growth. Because the benefit of inhaled glucocorticoids tend to be much greater than the risk, current guidelines for asthma management recommend these drugs for children while monitoring for evidence of any kind of complication. Long-term use of inhaled glucocorticoids may promote bone loss. Fortunately, the amount of loss is much lower than the amount caused by oral glucocorticoids. To minimize bone loss, patients should use the lowest dose that controls the symptoms, ensure adequate intake of calcium and vitamin D, and participate in weight-bearing exercises. There has been a concern that a prolonged therapy may increase the risk for cataract and glaucoma. Although this may be the issue of concern with continuous use of high-dose inhaled glucocorticoids, this problem is not associated with long-term use of a low to medium dose of an inhaled glucocorticoids. So that brings us to patient education on glucocorticoids. It's important that we inform patients that glucocorticoids are intended for preventative therapy, not for aborting or ongoing attacks. Instruct patients to administer glucocorticoids on a regular schedule and not as needed. Instruct patients on the proper use of their inhaler, having patients demonstrate a proper technique. If patients are prescribed both a SABA and a glucocorticoid, explain that delivery of glucocorticoids to the bronchial tree can be enhanced by inhaling a SABA 5 minutes before inhaling the glucocorticoid. Teach patients with chronic asthma to monitor and record their PEF, symptom frequency, and symptom intensity, nighttime awakenings, effects on normal activity, and the use of SABAs. Advise patients to rinse their mouth and gargle after dosing to minimize dysphonia and oropharyngeal candidiasis. Counsel patients to contact the clinic if they develop complications following a change from an oral to an inhaled glucocorticoid. Wearing a medical alert bracelet is advisable for patients who are at risk for adrenal insufficiency associated with a long-term systemic use. And lastly, advise patients to ensure adequate intake of calcium and vitamin D to decrease the risk of bone loss. That would also include performing weight-bearing exercises to provide additional protection. Bringing us to now the oral glucocorticoids. When used acutely, meaning less than 10 days, even in very high doses, oral glucocorticoids do not cause significant adverse effects. However, prolonged therapy, even in moderate doses, can be hazardous. Potential adverse effects include adrenal suppression, osteoporosis, hyperglycemia, peptic ulcer disease, and in the young patients, again, that growth suppression. Adrenal suppression is of particular concern, as discussed in Chapter 56. Prolonged glucocorticoid use can decrease the ability of the adrenal cortex to produce glucocorticoids of its own. This can be a life-threatening at times of severe physiologic stress. So, your surgeries, trauma, or any kind of systemic infection. Because high levels of glucocorticoids are required to survive severe stress, and because adrenal suppression prevents production of the endogenous glucocorticoids, patients must be given increased doses of oral or IV glucocorticoids at times of stress. Failure to do so can prove to be fatal. Bringing us to the compensating for adrenal insufficiency. When patients have a prolonged systemic glucocorticoid therapy, the adrenal glands decrease their endogenous production of glucocorticoids. If systemic therapy is stopped suddenly, as when switching from an oral therapy to an inhaled therapy, the patient can die. Similarly, during times of severe physical stress, when the body would normally produce a high level of glucocorticoids, if the dose of the systemic glucocorticoids is not increased to compensate, the patient can die. What important lesson can you take from this, therefore? When discontinuing a systemic glucocorticoid, you must be sure it is done gradually to allow the body to resume producing the endogenous hormone. On the other hand, if a patient is taking systemic glucocorticoids, experiences severe physical stress, such as a motor vehicle crash, or is scheduled for a stressful procedure, such as a surgery, you must prescribe additional glucocorticoids to supplement for the endogenous hormone that the patient cannot produce. Adrenal suppression is also a concern when discontinuing prolonged use of oral glucocorticoids or when transferring from an oral route to the inhaled route. Several months are required for recovery of an adrenocortical function so it is important to decrease the dosage gradually. Throughout this time, all patients, including those that switched to inhaled glucocorticoids, must be given supplemental oral or IV glucocorticoids at times of severe stress. A complete list of contraindications to oral glucocorticoids is presented in the prescribing and monitoring considerations sections towards the end of this chapter, so it will be discussed. Preparation, dosage, and administration. Your inhaled glucocorticoids. 6 glucocorticoids are available for inhalation. If you look at the upcoming table, you'll see them. 4 are available in MDIs. 3 are available in DPIs, and 1 is available in suspension for nebulization. Inhaled glucocorticoids are administered on a regular schedule, again, not as needed. Pediatric and adult dosages are shown in the table as well. The dosage should be kept as low as possible, again, to minimize that adrenal suppression, possible bone loss, and any other adverse effects. So here we're taking a look at the inhaled glucocorticoid formulation and dosage table. A great spot to hit pause. Nebulized budesonide, also known as Pulmicort, is the first inhaled glucocorticoid formulation for nebulizing dosing. The product is approved for maintenance therapy of persistent asthma in children in 1 to 8 years old. Improvement should begin in 2 to 8 days. Maximal benefit may take 4 to 6 weeks to develop, however. Budesonide suspension is available in 2 ml ampules containing 250 to 500 micrograms of the drug. Administration is done via a jet nebulizer equipped with a mouthpiece or face mask. Ultrasonic nebulizers, however, should not be used. The administration can take anywhere between 5 to 10 minutes. For children who are not taking an oral glucocorticoid, the initial dose is 500 micrograms per day, or 2 doses. For children who are taking an oral glucocorticoid, the initial dose is 1,000 micrograms in 1 or 2 doses. After 1 week, the dosage of the oral glucocorticoid should start to be tapered off. Your oral glucocorticoids, your methylprednisolone or prednisone, and prednisolone are preferred glucocorticoids for oral therapy of asthma. The dosage is the same regardless of the drug. When beginning therapy with oral glucocorticoids, dosing initially focuses on bringing symptoms under control. The National Asthma Education and Prevention Program guidelines recommend an initial burst of 40 to 60 milligrams administered daily for 3 to 10 days for adults. The initial pediatric dosage is 1 to 2 milligrams per kilo per day, again for 3 to 10 days. Therefore, the typical dosage is 0.25 to 2 milligrams per kilogram daily, or every other day for children younger than 12, and 7.5 to 60 milligrams daily, or every other day for older children and adults. For long-term treatment, alternate date dosing is recommended to minimize adrenal suppression. After symptoms have been controlled for 3 months, dosages should be decreased gradually to establish the lowest dosage that can keep the patient free of symptoms. As discussed previously, the dosage of oral glucocorticoids must be increased during times of stress. Leukotriene modifiers. Leukotrienes. Modifiers suppress the effects of leukotrienes, which are compounds that promote smooth muscle constriction, blood vessel permeability, and inflammatory responses through direct action, as well as through the recruitment of eosinophils and other inflammatory cells. In patients with asthma, these drugs can decrease bronchoconstriction and inflammatory responses, such as edema and mucus secretion. 3 leukotriene modifiers are currently available: Silutin, cefalucast, and montelukast. Silutin blocks leukotriene synthesis, whereas the other 2 block leukotriene receptors. All 3 drugs are dosed orally. Current guidelines recommend using these agents as second-line therapy and as add-on therapy when inhaled glucocorticoids alone are inadequate. Although generally well tolerated, all of these leukotriene modifiers can cause adverse neuropsychiatric effects, including depression, suicidal thinking, and suicidal behavior. So, speaking of the first, Silutin, which is an inhibitor of the leukotriene synthesis, is approved for asthma prophylaxis and maintenance therapy in adults and children 12 years and older. Symptomatic improvement can be seen within 1 to 2 hours of dosing. Because the effects are not immediate, Silutin cannot be used to abort an ongoing attack. Silutin is less effective than an inhaled glucocorticoid alone and appears to be less effective than a long-acting inhaled beta-2 agonist, as adjunctive therapy is in patients not adequately controlled with an inhaled glucocorticoid. The mechanism of action, therefore, the benefits derived from inhibiting 5-lipoxygenase, the enzyme that converts arachidonic acid into leukotrienes. This decreases the amount of leukotrienes available to induce inflammation. Pharmacokinetics. Succinyllutin is orally given and it undergoes rapid absorption. In both the presence and absence of food, the plasma levels peak 2 to 3 hours after dosing. Silutin is rapidly metabolized in the liver and metabolites are excreted in the urine. Its half-life is only 2.5 hours. Adverse effects. Silutin can injure the liver as evidenced by increased plasma levels of alanine aminotransferase, your ALT activity. A few patients have developed symptomatic hepatitis, which is reversed when the drug is withdrawn. To reduce the risk for serious liver injury, ALT levels should be monitored. The recommended schedule is once a month for 3 months, then every 2 to 3 months for the remainder of the first year, and periodically post-after. Post-marketing reports indicate that Silutin and the other leukotriene modifiers can cause adverse neuropsychiatric effects, again, including depression, anxiety, agitation, abnormal dreams, hallucinations, insomnia, irritability, restlessness, and suicidal thinking and behavior. If these develop, switching to a different medication should be considered. Silutin is metabolized by cytochrome P450, where it acts as an inhibitor of the CYP1A2 isoenzymes and can slow metabolism of drug substrates metabolized by this pathway, increasing their levels. Combined use with theophylline can markedly increase theophylline levels, so dosage of theophylline should be reduced. Silutin can also increase levels of warfarin and propranolol. Your preparation dosage and administration, therefore. Silutin is available in 600 mg release tablets, sold as Cyflo, and 600 mg extended release tablets as Cyflo CR. With the immediate release tablets, the recommended dose is 600 mg 4 times a day, where the extended release is 600 mg twice a day, taken within 1 hour of morning and evening meals. Bringing us to the next medication, Safirlukast, also known as Accolade, was the first representative of a unique group of anti-inflammatory agents, the leukotriene receptor antagonists. The drug is approved for maintenance therapy of chronic asthma in adults and children 5 years and older. The mechanism of action benefits derive in part from reduced infiltration of inflammatory cells, resulting in decreased bronchoconstriction. Pharmacokinetics. Cefalocast is administered orally and absorption is rapid. Food reduced absorption by 40%. Therefore, the drug should be administered at least 1 hour before a meal or 2 hours after. Cefalocast undergoes hepatic metabolism followed by fecal excretion. Its half-life is about 10 hours, but may be as long as 20 hours in an older adult. Adverse effects. The common side effects include headaches and gastrointestinal disturbances, both of which are infrequent. Arthralgia and myalgia may also occur. However, like Silutin, Cefalocast can cause depression, suicidal thinking, hallucinations, and other neuropsychiatric effects. A few patients have developed Churg-Strauss syndrome, a potentially fatal disorder characterized by weight loss, flu-like symptoms, and pulmonary vasculitis. However, in most cases, symptoms developed when glucocorticoids were being withdrawn, suggesting that the glucocorticoid withdrawal may be the contributing factor. Rarely, patients develop clinical signs of liver injury. If those, however, do occur, Cefalocast should be discontinued and liver function tests should be performed immediately. If test results are consistent with liver injury, Cefalocast should not be resumed. Curiously, signs of liver injury have developed mainly in females. Cefalocast inhibits several isoenzymes of cytochrome P450 and can suppress metabolism of other drugs, causing their levels to rise. Concurrent use can raise serum theophylline to toxic levels. Theophylline levels should be closely monitored, especially when cephalocast is started or stopped. Cephalocast can also raise levels of warfarin or Coumadin, and thus may cause bleeding. Its preparation, dosage, and administration is available in 10 and 20 milligram tablets. The dosage for adults and children 12 years and older is 20 milligrams twice a day, while the dosage for children 5 to 11 is 10 milligrams twice a day. Cephalocast should not be administered with food. Bringing us to montelukast. Montelukast, a leukotriene receptor blocker, is the most commonly used leukotriene modulator. The drug has three approved indications: the prophylaxis and maintenance therapy of asthma in patients at least 1 year old, the prevention of exercise-induced bronchospasms in patients at least 15 years old, and the relief of allergic rhinitis. Montelukast cannot be used for quick relief of an asthma attack because effects develop too slowly. For prophylaxis and maintenance therapy of asthma, maximal effects develop within 24 hours of the first dose and are maintained with a once daily dosing in the evening. In clinical trials, montelukast decreased asthma-related nocturnal awakening, improving morning lung function and decreased the need for a short-acting inhaled beta-2 agonist throughout the day. Although montelukast is approved for preventing exercise-induced bronchospasms, a short-acting beta-2 agonist is preferred. Its mechanism of action of montelukast is a high affinity for leukotriene receptors in the airway and on pro-inflammatory cells, such as your eosinophils. By occupying these receptors, the drug blocks receptor activation by the body's leukotrienes. Pharmacokinetics: montelukast is rapidly absorbed after oral administration. Bioavailability is about 64%. Blood levels peak in 3 to 4 hours after ingestion, and the drug is highly bound, almost more than 99%, to plasma proteins. Montelukast undergoes extensive metabolism by the hepatic cytochrome P450 enzymes, followed by the excretion in the bile. The plasma half-life ranges anywhere from 2.7 to 5.5 hours. Adverse effects: montelukast is generally well tolerated. In clinical trials, adverse effects were equivalent to those of a placebo. In contrast to Silutan and cephalocast, montelukast does not seem to cause liver injury. As with cephalocast, Churg-Strauss syndrome has occurred when glucocorticoid dosage was reduced. Post-marketing reports suggest a link between montelukast and a neuropsychiatric effects, especially mood changes and suicidality. Fortunately, these effects are rare. Montelukast appears devoid of serious drug interactions. Unlike Silutan and cephalocast, it does not increase levels of theophylline or Coumadin. Concurrent use of phenytoin can decrease levels of montelukast. Your preparation, dosage, and administration, therefore. Montelukast is available in three formulas: standard 10 milligram chewable tablets, or standard 10 milligram tablets, chewable tablets 4 to 5 milligrams, and oral granules 4 milligrams. Oral granules may be put directly in the mouth or be mixed with a spoonful of either applesauce, carrots, rice, or ice cream. For prophylaxis or chronic treatment of asthma, dosing is done once a day in the evening, with or without food. Dosage is based on the patient's age, so 15 and older, 10 milligrams daily; 6 to 14, 5 milligram chewable; 2 to 5, 4 milligram chewable, or the 4 milligram of oral granules; and then 1 year to 23 months, 4 milligrams of oral granules. To prevent exercise-induced bronchospasms, patients should take one 10 milligram tablet at least 2 hours before exercising. No additional dose should be taken for at least 24 hours. Patients already taking montelukast daily should not take any more to prevent EIB. That brings us to cromolyn. Cromolyn is an inhalation agent that suppresses bronchial inflammation. The drug is used for prophylaxis, not quick relief, in patients with mild to moderate asthma. Anti-inflammatory effects are less than with glucocorticoids. Therefore, cromolyn is not a preferred drug for asthma therapy. When glucocorticoids create problems, however, cromolyn may be prescribed as an alternative therapy. The mechanism of action, therefore. Cromolyn suppresses inflammation. It does not cause bronchodilation. The drug acts in part by stabilizing the cytoplasmic membrane of mast cells, preventing release of histamine and other mediators. In addition, cromolyn inhibits eosinophils, macrophages, and other inflammatory cells. Pharmacokinetics. Cromolyn is administered as a nebulizer. The fraction absorbed from the lungs is small and rarely produces significant systemic effects. Absorbed cromolyn is excreted unchanged in the urine. So its therapeutic use in chronic asthma, therefore. Cromolyn is an alternative to inhaled glucocorticoids for prophylactic therapy of mild persistent asthma. When it administered on a fixed schedule, cromolyn reduces both the frequency and intensity of asthma attacks. Maximal effects may take several weeks to develop. No tolerance to effects is seen with long-term use. Cromolyn is especially effective for prophylaxis of seasonal allergic attacks or for acute allergy prophylaxis immediately before allergen exposure. So before mowing the lawn, for example. Exercise-induced bronchospasm. Cromolyn can prevent bronchospasm in patients at risk for EIB. For best results, cromolyn should be administered 10 to 15 minutes before anticipated exertion, but no longer than 1 hour prior. There are patient education, so you want to instruct the patient on the proper use and care of a nebulizer. Again, for acute prophylaxis, instruct the patient to administer cromolyn 15 minutes before exercise or exposure to a precipitating factor. For long-term use, instruct patients to administer cromolyn on a regular schedule. Be sure to inform them that full therapeutic effects may take several weeks to develop. And again, teach patients with chronic asthma to monitor and record their PEF, symptom frequency and symptom intensity, their nighttime awakenings, effects on normal activity, and SABA use. Allergic rhinitis. Intranasal cromolyn can relieve symptoms of allergic rhinitis, but we'll discuss that more in Chapter 61. Adverse effects. Cromolyn is the safest of all anti-asthma medications. Significant adverse effects occur in fewer than 1 out of 10,000 patients, though occasionally a cough or bronchospasm occurs in response to the cromolyn inhalation. So its preparation, dosage, and administration. Cromolyn is administered using a power-driven nebulizer. The initial dosage for adults is 20 milligrams, 4 times a day. For maintenance therapy, the lowest effective dosage should be established. Bringing us to omalizumab. Omalizumab, or Xolair, is a monoclonal antibody with a unique mechanism of action. Antagonism of IgE, a type of antibody. The drug is a second-line agent, indicated only for allergy-related asthma and only when preferred options have failed. Omalizumab offers modest benefit and has significant drawbacks. The drug poses a risk for anaphylaxis and cancer, must be given subcutaneously, and costs more than $10,000 a year. Furthermore, its long-term safety is still unknown. So its mechanism of action: form complexes with free IgE in the blood and thereby reduces the amount of IgE available to bind with the receptor on the mast cells. This greatly reduces the number of IgE molecules on the mast cell surface and thus limits the ability of allergens to trigger the release of histamine, leukotriene, and other mediators that promote bronchospasm and airway inflammation. At recommended doses, omalizumab decreases free IgE in serum by 96%. When treatment stops, about 1 year is required for free IgE to return back to its normal pretreatment level. Therapeutic uses, therefore. Omalizumab is approved only for patients aged 12 and older and with moderate to severe asthma. That is 1, an allergy-related, and 2, cannot be controlled with an inhaled glucocorticoid. In clinical trials, the drug produced a modest decrease in the number of exacerbations and often permitted a reduction in glucocorticoid use. Because of its mechanism of action, omalizumab can only help patients whose asthma is caused by a specific allergen, such as pet dander or dust mite feces. Accordingly, a skin test or blood test proving allergen reactivity is required. Unless instructed otherwise, patients should continue all asthma medications they were using prior to using omalizumab. Its pharmacokinetics. Omalizumab is administered subcutaneously, and absorption is slow, producing peak levels in 7 to 8 days. Degradation occurs in the liver, and the drug's half-life is prolonged to about 26 days. It does, however, have a black box warning. Omalizumab carries a risk for anaphylaxis that may occur at any time during the course of treatment. Patients should be notified of signs and symptoms that necessitate seeking medical care. Patients should be routinely monitored after the administration in healthcare settings. Omalizumab can cause a variety of adverse effects. The most common are injection site reactions, viral infections, upper respiratory infections, sinusitis, headaches, and pharyngitis. Early clinical trials suggested a very small risk for cardiovascular problems and malignancy. A meta-analysis of post-marketing studies revealed no significant increase in cardiovascular events between subjects taking omalizumab and a placebo. There was a small increase in a rare malignancy occurring in subjects taking omalizumab, however, a clear relationship to the drug has not been established. Possible, possible adverse consequences of long-term IgE suppression is still unknown. Life-threatening anaphylaxis, characterized by urticaria and edema of the throat and or tongue, has occurred in less than 0.1% of patients. Anaphylaxis is most likely with the first dose, but can occur after receiving repeated doses with no apparent sensitivity. To minimize injury from anaphylaxis, patients should be observed for 2 hours for the first 3 doses, and for 30 minutes after all subsequent doses. Facilities for managing anaphylaxis should be available readily. Patients who experience a severe reaction should not, for obvious reasons, continue using the medicine. Its preparation, dosage, and administration is available in a powder of 202.5 milligrams in a single-use vial for the reconstitution of 1.4 ml of sterile water. Once dissolving the powder, which can take up to 20 minutes, yields a final solution of 150 milligrams and 1.2 ml. Administration by the sub-Q injection, which may take between 5 to 10 seconds because the solution is very viscous. The reconstituted solution should be used within 4 hours within room temperature or within 8 hours if stored cold. Again, the medication or the powder itself should be kept refrigerated. The size of each dose and the dosing interval are determined by the body weight and the total serum IgE. Measured at baseline, dosages range anywhere from 150 to 300 milligrams every 4 weeks, or to 225 to 375 milligrams every 2 weeks. No more than 150 milligrams, however, should be used at one injection site. So if a dose exceeds 150, it should be divided into more than one site. Which brings us to bronchodilators. Bronchodilators provide symptomatic relief in patients with asthma and COPD, but do not alter the underlying inflammation that is part of the disease process. This is why most patients who require a bronchodilator also use an inhaled glucocorticoid for long-term suppression of inflammation. Monotherapy with bronchodilator is appropriate only when asthma is very mild and attacks are infrequent. The beta-2 adrenergic agonist. Inhaled beta-2 agonists are the most effective drugs available for relieving acute bronchospasm and preventing exercise-induced bronchospasms. Virtually all patients with asthma use these first-line drugs as component of an asthma management regimen. The basic pharmacology of a beta-2 agonist is presented in Chapter 13. Discussion here is limited to their use in asthma. So, patients under care across the lifespan. Children. Although they may be used for younger children, SABAs are approved for children 2 years and older. Special delivery devices, such as nebulizers, may be used for very young children. Safety and efficacy of anticholinergics has not been established for children younger than 11 years. Eumethylxanthines are approved for children of all ages, including neonates. It is important to consider variable drug clearance across age ranges when dosing. In the pregnant woman, beta 2 agonists are classified in FDA pregnancy risk category C, owing to uterine relaxation. However, NAEPP guidelines note that benefits are greater than the risk. Pregnant women must have adequate respiratory exchange to ensure adequate oxygenation of the developing fetus. Anticholinergics are classified in FDA pregnancy risk category B. The methylxanthines are pregnancy risk category C. Breastfeeding women. Breastfeeding is not contraindicated with a beta 2 agonist or anticholinergics. However, manufacturers of both drugs recommend caution. Labeling for methylxanthines warns against breastfeeding only if the mother may have toxic levels. In the older adult, benefits exceed risks for beta 2 agonists and anticholinergics. Systemic anticholinergics are included in Beer's criteria for potentially inappropriate use in older adults. They should not be substituted for inhaled anticholinergics. Older patients are at a much higher risk for toxicity when taking methylxanthines. So its mechanism of action. The beta 2 agonists are sympathomimetics, drugs that activate beta 2 adrenergic receptors. By activating beta 2 receptors in smooth muscles of the lung, these drugs promote bronchodilation and thus relieve a bronchospasm. In addition, beta 2 agonists have limited role in suppressing histamine release in the lung and increase ciliary motility. The classification by route and time course. Beta 2 agonists may be administered orally or by inhalation, and their effects may be brief or prolonged. All of the oral agents are long acting. Among the inhaled agents, some are short acting and some are long acting. With these short acting inhaled preparations, effects begin almost immediately, peak in 30 to 60 minutes, and persist for 3 to 5 hours. Because of this time course, the short-acting beta-2 agonists, the SABAs, can be used to abort an ongoing attack, but cannot be used for prolonged prophylaxis. With the inhaled long-acting beta-2 agonists, or LABAs, onset depends on the drug. With formoterol and aformoterol, onset is relatively rapid, whereas with salmeterol, onset is delayed. However, because these drugs are used on a fixed schedule for long-term control, the difference in onset is not very important. Use in asthma and chronic obstructive pulmonary disease. A beta 2 agonists are employed for quick relief and long-term control. Drug selection depends on the goal. In the inhaled short-acting beta-2 agonists, SABAs are taken as needed to abort an ongoing attack. In patients with exercise-induced bronchospasms, they are taken before exercise to prevent an attack from occurring. For hospitalized patients undergoing a severe acute attack, a nebulized SABA is the traditional treatment of choice. However, delivery with an MDI in the outpatient setting may be equally effective. Long-term or long-acting inhaled beta-2 agonists. Patients who experience frequent attacks may be prescribed a LABA for long-term control. Dosing is done on a fixed schedule and not as needed. LABAs are preferred over SABAs for patients with stable COPD. In patients with asthma, however, LABAs are not first-line therapy, and they must always be combined with a glucocorticoid. In fact, their use alone in asthma is contraindicated because LABA monotherapy has been associated with an increased incidence of asthma-associated death. For combined LABA glucocorticoid therapy, the U.S. Food and Drug Administration recommends using a product that contains both drugs in the same inhaler. So here is our black box warning then for long-acting beta-adrenergic agonists. All LABAs carry a risk for asthma-related death. To attenuate this risk, the use of a LABA as monotherapy is contraindicated. LABA should only be prescribed as a component of a long-term therapy with medications, such as an inhaled glucocorticoid. Oral beta-2 agonists. These drugs are used only for long-term control. Onset is too slow to abort an ongoing attack. Like the long-acting inhaled beta-2 agonists, the oral agents are not first-line therapy. So adverse effects. Your inhaled preparation of short-acting. Inhaled SABAs are well tolerated. Systemic effects, however, include tachycardia, angina, and tremors, which can occur but are usually minimal. Your inhaled preparation of the long-acting, or LABAs, may increase the risk for severe asthma and asthma-related death when used in monotherapy for long-term control. To minimize risk, LABAs should be used only in patients taking a recommended medication for long-term control, and only if that medication has been inadequate by itself. LABAs should never be the first-line therapy for prolonged control and should never be used alone. There's a reason this is repeated multiple times. So, important patient education pieces regarding a beta-2 adrenergic. Instruct patients on the proper use of inhalers, having the patient demonstrate proper technique. For patients who have a difficulty with hand-breath coordination, using a spacer with a one-way valve may improve that result. Advise patients with asthma to assess PEF daily and compare with personal best. Counsel patients to keep a record of these assessments, along with symptom frequency and symptom intensity, nighttime awakenings, and effects on normal activity, and how often you use your SABAs. Inform patients who are using MDIs or DPIs that, when 2 inhalations are needed, an interval of at least 1 minute should elapse between inhalers. Instruct patients to report chest pain associated with changes in heart rate or rhythm. This could indicate cardiac stress secondary to an adrenergic effect. Warn patients against exceeding recommended dosages. If worsening symptoms require more frequent use of a SABA, the provider should be notified. Inform patients that inhaled LABAs should be taken on a fixed schedule and not as needed, and always in a combination with an inhaled glucocorticoid. Instruct patients to take oral beta-2 agonists on a fixed schedule and not as needed. Sustained release preparations should be swallowed intact without crushing or chewing the medicine. Which brings us to oral preparations. The selectivity of a beta-2 adrenergic agonist is only relative, not absolute. Accordingly, when these drugs are administered orally, they are likely to produce some activation of a beta-1 receptor in the heart. If dosage is excessive, the stimulation of a cardiac beta-1 receptor can cause angina pectoris and tachydysrhythmias. Patients should be instructed to report chest pain or changes in the heart rate or rhythm. An oral beta-2 agonist often causes a tremor by activating beta-2 receptors in skeletal muscle. Tremors can be reduced by lowering the dosage. With continued drug use, tremor declines spontaneously. So, preparation, dosage, and administration. 9 selective beta-2 agonists are available. Some are used for quick relief and some for long-term control. Here is a wonderful spot to hit pause so you can look at all the different medications. You got your albuterol, your ProAir, Proventil, levobuterol, Xopenex, and then your inhaled long-acting. The prior was short-acting. Apologies. Your long-acting, though, your aclidinium bromide, your aformoterol, formoterol, Foradol, your perforomist, indacaterol, olodaterol, salmeterol, and then your oral agents. Again, your albuterol uh, and Vospira, terbutaline. Inhaled preparations for quick relief. To provide quick relief, beta-2 agonists must be administered by inhalation. Three types of devices can be used. Again, the MDIs, DPIs, and nebulizers. For drugs administered with an MDI or DPI, the initial dose schedule is 1 or 2 inhalations, 3 to 4 times a day. Additional drugs are added to the asthma management regimen with the goal of decreasing the reliance on a SABA to no more than twice a week. So here's a classification of asthma severity and the recommended step for initial treatment. Whether it's your symptoms, your nighttime awakening, SABA used to control those symptoms, the effects on normal activity, lung function tests, and then the future risk of exacerbations. When 2 inhalations are needed, an interval of 1 minute or longer should separate them. During this interval, some bronchodilators develops, facilitating penetration of the second inhalation. For certain patients, nebulizers may be superior to inhalers. Some patients who have become unresponsive to a beta-2 agonist delivered by an inhaler may respond to the same drug when it is given via a nebulizer. The nebulizer delivers a dose slowly. As the bronchi gradually dilate, the drug gains deeper and deeper access to the lungs. Inhaled preparations for long-term control. 3. Single inhaled LABAs are approved for the treatment of asthma. Your salmeterol, formoterol, and aformoterol. Vilanterol, another LABA, is available only in the combination with a glucocorticoid. That's your Brio-Ellipta. LABAs have a long-term duration of action and thus are suited for long-term control. Dosing is every 12 hours. If supplemental bronchodilation is needed between those doses, a SABA should be used. As discussed previously, LABAs are not first-choice agents for long-term control, and they should not be used alone. Rather, they should always be combined with an inhaled glucocorticoid, preferred in the same inhaler device. Although salmeterol is usually inhaled twice daily, with continuous use, more frequent dosing may be needed because benefits seem to persist for a shorter time as the duration of treatment increases. Your oral preparations for long-term control. 2 oral beta-2 agonists, albuterol and terbutaline, are approved for long-term control of asthma. Dosing is 3 to 4 times a day. Turbuhaler offer a 500 microgram actuation for PR and dosing. Your methylxanthines. We first encountered the methylxanthines in chapter 29. As discussed there, the most prominent action of these drugs are central nervous system excitation and bronchodilation. Other actions include cardiac stimulation, vasodilation, and diuresis. Theophylline is the principal methylxanthine employed in asthma. Benefits derive primarily from bronchodilation. Theophylline has a narrow therapeutic range, so dosage must be carefully controlled. The drug is usually administered by mouth, but may also be administered IV. The mechanism of action produces bronchodilation by relaxing smooth muscle of the bronchi. Although the mechanism of bronchodilation has not firmly been established, the most probable is blockade of receptors for adenosine. The use in asthma and chronic obstructive pulmonary disease. Oral theophylline is used for maintenance therapy of chronic stable asthma. Although less effective than beta-2 agonists, theophylline has a longer duration of action. With regular use, theophylline can decrease the frequency and severity of asthma attacks. Because its effects are prolonged, theophylline may be most appropriate for patients who experience nocturnal attacks. Once standard therapy is in management of COPD, theophylline is no longer recommended. Evidence-based guidelines recommend its use only if beta-2 agonists and anticholinergics are not available or if the patient cannot afford long-term therapy with other drugs. IV theophylline has been employed in emergencies. However, the drug is no more effective than a beta-2 agonist and glucocorticoids and is clearly more dangerous. Its pharmacokinetic absorption, oral theophylline, is available in a sustained release formulation as an elixir. Absorption from sustained release preparation is slow, but the resulting plasma level is stable, being free of a wide fluctuation associated with immediate release products. Absorption from some sustained release preparations can be affected by food. The metabolism. Theophylline is metabolized in the liver. Rates of metabolism are affected by multiple factors, age, disease, and drugs, and show wide individual variations. As a result, the plasma half-life of theophylline varies considerably among patients. For example, although the average half-life in non-smoking adults is about 8 hours, the half-life can be as short as 2 hours in some adults and as long as 15 hours in others. Smoking either tobacco or marijuana accelerates metabolism and decreases the half-life. The average half-life in children is 4 hours. Metabolism is slowed in patients with certain pathologies, so your heart disease, liver disease, and a prolonged fever. Also, some drugs decrease theophylline metabolism, including fluoroquinolone and cimetidine. Other drugs, phenobarbital, accelerate metabolism. Because of these variations in metabolism, dosage must be individualized. Drug levels. Safe and effective therapy requires a periodic measurement of theophylline blood levels. Traditionally, dosage has been adjusted to produce theophylline levels between 10 and 20 micrograms per ml. However, many patients respond well at 5 micrograms per ml, and as a rule, there's little benefit to increasing levels above 15 micrograms. Therefore, levels between 5 and 15 micrograms per ml are appropriate for most patients. At levels above 20 micrograms, the risk for significant adverse effects are high. So, toxicity, patient education. Warn patients that if a dose is missed, the following dose should not be doubled. Instruct patients to swallow enteric-coated and sustained release formulations intact without crushing or chewing. Warn patients against consuming caffeine-containing beverages and other sources of caffeine. Explain that caffeine can intensify adverse effects while decreasing the theophylline breakdown. Instruct patients to call the clinic if they start developing symptoms of nausea, vomiting, abdominal discomfort, diarrhea, insomnia, restlessness, or palpitations, as these may signify theophylline toxicity. Warn patients that smoking tobacco or marijuana can increase theophylline clearance, resulting in ineffective dosaging. So, symptoms. Toxicity is related to theophylline levels. Adverse effects are uncommon at plasma levels below 20 micrograms. At 20 to 25 micrograms per ml, relative mild reactions occur. Again, nausea, vomiting, diarrhea, insomnia, and restlessness. Serious adverse effects are most likely to start at levels above 30 micrograms per ml. These reactions can include severe dysrhythmias, ventricular fibrillation, and convulsions that can be highly resistant to treatment. Death may result from cardiorespiratory collapse. Treatment. At the first indication of toxicity, dosing with theophylline should stop. Absorption can be decreased by administering activated charcoal together with cathartic. Ventricular dysrhythmias respond to lidocaine. IV diazepam may help control seizures. Its drug interactions, therefore, with caffeine. Caffeine is a methylxanthine with pharmacologic properties, like those of theophylline. Accordingly, caffeine can intensify the adverse effects of theophylline on the CNS and heart. In addition, caffeine can compete with theophylline for drug metabolizing enzymes, causing theophylline levels to rise. Because of these interactions, individuals taking theophylline should avoid caffeine-containing beverages and other sources of caffeine. Again, speaking on the behalf of tobacco and marijuana smoke, smoking tobacco or marijuana can induce theophylline metabolism, resulting in increased drug clearance of up to 50% in adults and 80% in older adults. So, consequently, if a smoking patient stops smoking, but the dose of theophylline is not decreased, the patient is now at risk for theophylline toxicity over time. Drugs that reduce theophylline. Again, there's both ends of the spectrum. Several agents, including the phenobarbital, phenytoin, and ribampin, can lower theophylline levels by inducing hepatic drug metabolism enzymes. Concurrent use of these agents may necessitate an increase in theophylline dosage. And then drugs that increase theophylline levels. Several drugs, including cimetidine and fluoroquinolone antibiotics, reciprofloxacin, can elevate plasma levels of theophylline, primarily by inhibiting hepatic metabolism. To avoid theophylline toxicity, the dosage of theophylline should be reduced when the drug is combined with these agents. Bringing us to the formulations. Theophylline is available for IV and oral use. For IV use, general solutions are available in the concentration of 400 milligrams per 250 ml, 400 milligrams in 500 ml, 800 milligrams in 500 ml. For oral use, the following concentration is available. Elixophyline, oral elixir, is 80 milligrams in 15 ml, and a generic with the same dosaging. Theocron 12-hour extended release in 100, 200, and 300 milligrams, where the generic route also has a 450 dosage. Theo 24-hour release extended capsule comes in 100, 200, 300, and 400 milligrams, whereas the generic route only comes in 400 and 600 milligrams. Unlike the elixir and oral solutions, the sustained release tablets and capsules produce drug levels that are relatively stable. Accordingly, the sustained release formulations are preferred for routine therapy. Dosage and administration. When oral, dosage must be individualized to minimize chances of toxicity. Doses should be low initially and then gradually increase. If a dose is missed, the following dose should not be doubled, because doing so could produce toxicity. Smokers require a higher than average dose. Conversely, patients with heart disease, liver dysfunction, and prolonged fever are likely to require lower doses. Patients should be instructed not to chew the sustained release tablets or capsules. Products. Information should be consulted with compatibility with food. The initial dosage is based on the age and weight of the patient and on the presence or absence of factors that can impair theophylline elimination. Specific initial dosages are described in the prescribing information in the packaging insert. As noted previously, maintenance doses should be adjusted to produce drug levels in a therapeutic range between 5 to 15 micrograms per ml. IV. IV theophylline is reserved for emergencies. Administration must be done slowly because rapid injection can be fatal. Cardiovascular reactions. IV theophylline is incompatible with many drugs. According to the compatibility, should be verified before mixing theophylline with any other IV agent. For specific IV dosages, refer to the discussion on aminophylline below, which is our next section. Aminophylline is a theophylline salt that is considerably more soluble than theophylline by itself. In solution, each molecule of aminophylline dissociates to yield two molecules of theophylline. Hence, the pharmacologic property of aminophylline and theophylline are identical. Aminophylline is available in formulation of oral and IV dosing. IV administration is employed most often. So, its administration and dosage IV. Because of its relatively high solubility, aminophylline is the preferred form of theophylline for IV use. Infusions should be done slowly because rapid injection can produce severe hypotension and death. So no faster than 25 micrograms per minute. The usual loading dose is 5.7 milligrams per kilo. The maintenance infusion rate should be adjusted to provide a plasma level of theophylline that are within the therapeutic range of 10 to 20 micrograms per ml. Aminophylline solutions are incompatible with a number of drugs. Therefore, compatibility must be verified before mixing aminophylline with an additional IV source. Orally, aminophylline is available in 100 and 200 milligram tablets. Dosing guidelines are the same as for theophylline. Bringing us to anticholinergic drugs. Anticholinergic drugs improve lung function by blocking the muscarinic receptors in the bronchi, reducing bronchoconstriction. Two agents are available, ipratropium and tiotropium. These drugs are approved only for COPD, but are used off-label for asthma. Both drugs are administered via inhalation. The principal difference between the two is a pharmacokinetic. Tiotropium has a much longer duration of action and thus can be dosed less often. With both drugs, systemic effects are considered minimal. So, let's start with ipratropium. Actions and therapeutic use. Ipratropium is an atropine derivative administered by inhalation to relieve a bronchospasm. The drug has FDA approval only for bronchospasm associated with COPD, but is often used off-label for asthma and is included in concurrent evidence-based guidelines from the NAEPP for asthma management. Like atropine, ipratropium is a muscarinic antagonist by blocking muscarinic cholinergic receptors in the bronchi. Ipratropium prevents bronchoconstriction. Therapeutic effects begin within 30 seconds, reach 50% of their maximum in 3 minutes, and can last up to 6 hours. Ipratropium is effective against allergen-induced asthma and exercise-induced bronchospasms, but is less effective than the beta-2 agonist. However, because ipratropium and the beta-2 adrenergic agonists promote bronchodilation by different mechanisms, their beneficial effects are additives. Adverse effects. Systemic effects are minimal because ipratropium is a quaternary ammonium compound and therefore always carries a positive charge. As a result, the drug is not readily absorbed from the lungs or from the digestive tract. The most common adverse reaction are dry mouth and irritation of the pharynx. If systemic absorption is sufficient, the drug may raise intraocular pressure in patients with glaucoma. Adverse cardiovascular events, such as a heart attack, stroke, or death, have occurred in people taking ipratropium. However, because absorption is minimal, it seems unlikely that ipratropium is or was the cause. Preparation, dosage, and administration. The medication is supplied in one solution of a 500 microgram per vial and in MDIs that deliver 17 micrograms per actuation. For patients using an MDI, the usual dosage is 2 inhalations 4 times a day, and the maximal dosage is 12 inhalations in 24 hours. For patients using the solution, the usual dosage is 500 micrograms 3 or 4 times a day, administered via a nebulizer. That brings us to tiotropium. Actions and therapeutic use. The generic name is Spiriva. which is a long-acting inhaled anticholinergic agent approved for the maintenance therapy of bronchospasm associated with COPD. The drug is not approved for asthma but has been used off-label for patients who have not responded to other medicines. Like ipratropium, tiotropium relieves bronchospasm by blocking muscarinic receptors in the lungs. Therapeutic effect begins in about 30 minutes after the inhalation and peaks in 3 hours, and persists about 24 hours. With subsequent doses, bronchodilation gets better and better, reaching a plateau after 8 consecutive doses, or 8 days. Compared with ipratropium, tiotropium is more effective and its dosing schedule is more convenient, once daily versus 4 times daily. Tiotropium is indicated only for long-term maintenance. For rapid relief of ongoing bronchospasm, a patient should use a SABA. Adverse effects. The most common is dry mouth, which occurs in 16% of patients. Fortunately, this response is generally mild and diminishes over time. Patients can suck on a sugarless candy for relief. Systemic anticholinergic effects such as constipation, urinary retention, tachycardia, and blurred vision are minimal. Like ipratropium, tiotropium is a quaternary ammonium compound, and thus absorption into the systemic circulation is very limited. Again, similar to ipratropium, tiotropium has been associated with adverse cardiovascular events. However, because of the absorption is low, it is unlikely that it is the cause. The preparation and dosage, as well as the administration. Spiriva is supplied both as a Respimat inhaler at 18 micrograms capsules, along with a HandiHaler DPI device. Dosage for the Respimat inhaler is 2 inhalations once daily. Dosage of the HandiHaler DPI is 18 micrograms once daily. The administration is via inhalation only. The capsules should not be swallowed. Bringing us to aclidinium. Actions and therapeutic use. The other name to it is Tudorza, which received FDA approval back in 2012, which is indicated for the management of a bronchospasm associated with COPD. It relieves bronchospasm by blocking muscarinic receptors in the lungs. Peak levels have occurred within 10 minutes of the drug delivery. However, it is intended only for the maintenance therapy and not for acute symptom relief. Adverse effects and reactions reported in the clinical trials include headache, nasopharyngitis, and a cough. As with any anticholinergic, there is a theoretical risk of worsening narrow-angle glaucoma, urinary retention, and other systemic anticholinergic effects. However, these have not been reported. Its preparation, dosage, and administration. Aclidinium is available as a breath-activated multi-dose DPI. Each metered dose contains 400 micrograms of aclidinium bromide, and it's recommended to be used twice a day. Bringing us to umeclidinium. Its action and therapeutic use, also known as Ellipta, which received FDA approval in 2013, is the newest long-acting anticholinergic indicated for the management of a bronchospasm associated with COPD, and very common today in the hospital setting. In addition to its availability as a single agent, it is also available as a combo drug with vilanterol as the Enora ellipta. Both the single and combo drug are indicated for COPD maintenance therapy only. They are not approved for asthma treatment. Adverse effects. Spiriva contains lactose as a component of the powder mix. Theoretically, it may cause severe hypersensitivity reactions when taken by people who have a milk protein allergy. In clinical trials, adverse effects were negligible. Nasopharyngitis was reported by 8% of patients. However, this was reported by 7% of those taking a placebo. Similarly, 5% reported upper respiratory tract infections, yet this was reported by 4% taking a placebo. Although it is possible for this anticholinergic drug to cause typical anticholinergic adverse effects because it is inhaled, the likelihood of this occurrence is considered low. Your preparation and dosage. Your Ellipta is available for inhalation. Each meter dose contains 62.5 micrograms of umeclidinium. It should be used once every 24 hours. Which brings us to the glucocorticoid long-acting beta agonist combination. These are our combo drugs. Your fluticasone salmeterol, also known as Advair discus. Your Brio Ellipta, your Symbicort, Dulera, are available in fixed-dose combination for inhalation therapy of asthma and COPD. The glucocorticoids, the fluticasone, budesonide, and mometasone, provide anti-inflammatory benefits, and the LABAs provide bronchodilation. All four products are indicated for long-term maintenance in adults and children. These combinations are more convenient than taking a glucocorticoid and LABA separately, but have the disadvantage of restricting dosage flexibility. These products carry a black box warning about possible increased risk for asthma severity and asthma-related death. However, because the LABA is combined with a glucocorticoid, risk should be minimal. The four combination products have not been directly compared. Nonetheless, when used in equivalent dosages, they are likely to be equally effective. So, starting off with the first, fluticasone / salmeterol are available in a DPI sold as Advair discus and an MDI. Advair discus is approved for patients 4 years and older, where the MDI is approved for patients 12 and older. Advair discus is available in 3 strengths and delivers the following dosages: 50/100 micrograms, 50/250 micrograms, and 50/500 micrograms. Dosing consists of 1 inhalation every morning and evening. The dose of the fluticasone should be equivalent to the dosage of the glucocorticoid already in use. The Advair HFA is available in 3 strengths: the 21/45 microgram, 21/115 microgram, and the 21/230 microgram. Dosing again consists of 2 inhalations every morning and evening. As with Advair discus, the fluticasone dosage should be equivalent to the dosage of the glucocorticoid in use. That brings us to the combo drug Brio Ellipta. This is your fluticasone vilanterol, which is approved only for adults. It is indicated for the treatment of both asthma and COPD. So Brio Ellipta is available in 2 strengths, 100/25 microgram and 200/25 microgram per actuation of the dry powder delivery device. Dosing for both conditions is 1 inhalation once daily. This is a maximal recommended dose for COPD, and that would be the 100/25 microgram. For asthma, if there is an inadequate improvement, patients may use 200 micrograms -25 once daily. Which brings us to our next combo drug, also known as Symbicort budesonide formoterol, is supplied in an MDI for the use of patients 12 years and older. Symbicort is available in 2 strengths, 80/4.5 and 160/4.5 micrograms per inhalation. That's 2 inhalations every morning and evening, and patients currently taking a low to medium glucocorticoid dose should start at 80/45. Patients taking a medium to high glucocorticoid should be at the 160/450 microgram formula. Next up, Dulera, also known as the mometasone formoterol. is an MDI that is available for use in patients 12 and older. Dulera is available in two strengths, 100-5 micrograms and 200-5 micrograms per inhalation. Dosing consists of 2 inhalations every morning and evening, and patients taking a low to medium glucocorticoids should start low, and those with a medium to high should start high. Your beta-adrenergic agonist anticholinergic combo drugs. The combination of a beta-2 agonist and a cholinergic antagonist optimizes the bronchodilation by capitalizing on the unique action of the individual agents. As mentioned previously, a beta-2 agonist promotes bronchodilation by stimulating adrenergic receptors. In the lung, this relaxes smooth muscle in the airway. Cholinergic antagonists promote bronchodilation by blocking cholinergic receptors. This relaxes smooth muscle tone by preventing stimulation of cholinergic receptors. Additionally, a beta-2 agonist primarily affects the bronchioles, whereas anticholinergics primarily affects the bronchi. This action on different areas of the airway further enhances bronchodilation. All beta agonist and anticholinergic combinations are inhaled. 4 combinations are available. It's your albuterol ipratropium, your indacaterol glycopyrronium, olodaterol tiotropium, and volanterol umeclidinium. These are only approved for the management of COPD. However, Combivent has been used off-label to treat asthma. So, we'll start with the first one, your Combivent Respimat, or Duoneb, the ipratropium albuterol. Is available in 2 formulas. The solution for a Duoneb is an inhaler, contains 500 micrograms of ipratropium and an anticholinergic and 2,500 micrograms of albuterol, a SABA, in a 3 ml single-use vial. The recommended dose is the 3 ml administered 4 times a day by oral inhalation using a nebulizer. The Combivent Respimat inhaler delivers 20 micrograms of ipratropium and 100 micrograms of albuterol with each actuation. The recommended dosage is 1 inhalation 4 times a day for a maximum of 6 inhalations in 24 hours. Your indicaterol glycopyrronium, also known as Utibron neohaler, contains 27.5 micrograms of the LABA and 15 micrograms of the anticholinergic glycopyrronium per inhalation. Dosing is twice daily on a scheduled regimen. Your olodaterol tiotropium is a LABA combined with tiotropium and anticholinergic. There's a 2.5 microgram of olodaterol and 2.5 microgram of tiotropium per actuation, where the dosing is 2 inhalation once a day. The last one, the Enoroellipta, the umeclidinium and volanterol, is a combo product that contains 62.5 micrograms of umeclidinium and 25 micrograms of volanterol. This one should be inhaled once a day. So that brings us to the management of asthma. Back in 2007, the National Asthma Education and Prevention Program of the National Heart, Lung, and Blood Institute issued an expert panel report for the guidelines for the diagnosis and management of asthma. These are still the most current US recommendation for asthma management. And you can take a look at the website here on the screen to take a look at a closer, review. In this EPR3, the management recommendations are made for 3 age groups: 0 to 4, 5 to 11, and 12 years and older. Again, the recommendations for all three groups are similar, although there are some important differences. For the recommendations that apply to younger patients, make sure you take a look at this EPR3 form. Measuring lung function. Before considering asthma therapy, we need to address tests of lung function. And there's three tests that you would want to take a look at. The first being a forced expiratory volume in 1 second, which is the most useful test of lung function. To determine the forced expiratory volume, or FEV1, the patient inhales completely and exhales as completely and forcefully as possible into a spirometer. The spirometer measures how much air was expelled during the first second of exhalation. Results are compared with a predictive normal volume for a normal, healthy person of a similar age, sex, height, and weight. For a patient with asthma, that number might be 75% of the predicted value. Second test, forced vital capacity, or FVC, also measured with a spirometer, is defined as a total volume of air the patient can exhale after full inhalation. And then that third one is the FEV over FVC, is the fraction or percentage of vital capacity exhaled during the first second of forced expiration. The normal values range from 85% down to 70%. In a patient with asthma, the value may be in the normal range, or it may be reduced by 5%, depending on how severe that asthma is. We also have one more test, your peak expiratory flow, which is defined as the maximal rate of airflow during expiration. To determine the PEF, the patient exhales as forcefully as possible into a peak flowmeter, a relatively inexpensive handheld device. Patients should measure their peak flow every morning. If the value is less than 80% of their personal best, more frequent monitoring should be considered. So we also have different classifications of asthma severity. As described in the EPR3, chronic asthma has four classes of increasing severity, starting with intermittent, mildly persistent, moderately persistent, and then lastly, severely persistent. Diagnostic criteria for these classes are shown in the following table. Note that severity classification is based on two separate domains, impairment and risk. Impairment refers to the effect of asthma on the quality of life and the functional capacity in the present. Risk refers to the possible adverse events in the future, such as an exacerbation or a progressive loss of lung function. As we progress from the intermittent asthma to severe persistent asthma, both impairment and risk factors increase. Asthma symptoms occur more often and last longer. The use of SABAs for symptomatic control increases. Limitations on physical activity becomes more substantial. Your FEV1 decreases to less than 60% of the predicted, and your FEV over FVC jumps to 5% or more below the normal range. And the number of exacerbations that require a glucocorticoid begins to increase. It is important to note that the two domains of asthma, impairment and risk, may respond differently to drugs. Furthermore, patients can have a high risk for future events, even if their current level of impairment is considered low. So, treatment goals. Treatment of chronic asthma is directed at two basic goals, reducing impairment and reducing risk. Components of each goal are listed here. So, reducing impairment, preventing chronic and troublesome symptoms such as coughing and breathlessness after exertion, reducing the use of SABAs for symptom relief for 2 days a week or less, maintaining a normal pulmonary function, maintaining normal activity levels, including exercise and attendance at school and work, and meeting patient and family expectations regarding their asthma care. Then, to reduce the risk, preventing recurrent exacerbations, minimizing the need for emergency department visits and hospitalizations, preventing progressive loss of lung function, and providing maximal benefit with minimal adverse effects. So, the chronic drug therapy. In patients with chronic asthma, drugs are employed in two ways. Some agents are taken to establish long-term control, and some are taken for quick relief of an ongoing attack. The long-term control drugs are taken every day, whereas the quick relief drugs are taken as needed. Of the long-term control agents in current use, inhaled glucocorticoids are by far the most important. With regular dosing, these drugs reduce the frequency and severity of attacks, as well as the need for quick relief medicines. Of the quick relief drugs in current use, inhaled SABAs are the most important. These drugs act promptly to reverse bronchoconstriction and provide rapid relief from cough, chest tightness, and wheezing. So if you take a look, here is a good spot to pause. You can take a look at the drugs for asthma. For chronic drug therapy, EPR3 recommends the stepwise approach, in which drug dosages and drug classes are stepped up as needed and stepped down when possible. 6 steps are described in the following table. The basic concept is simple. First, all patients start with step 1. Should use an inhaled SABA as needed for quick relief. Second, all patients except for those on step 1 should use long-term medication control to provide baseline control. Third, when a patient's move up a step owing to increased impairment or risk, dosage of the control medication is increased or another control medication is added, or both. And fourth, after a period of sustained control, moving down a step should be tried and trialed. So here is that stepwise approach, an awesome spot to hit pause so you can take a look. For patients just beginning drug therapy, the step they start on is determined by the pre-treatment classification of asthma severity. For example, a patient diagnosed with an intermittent asthma would begin at step 1, whereas a patient diagnosed with moderate persistent asthma would begin at step 3. After treatment has been ongoing, stepping up or down is based on the assessment of asthma control. Like the diagnosis of a pretreatment severity, assessment of control is based on 2 domains: current impairment and future risk. In EPR3, 3 classes of control are defined: well controlled, not well controlled, and very poorly controlled. Your diagnostic criteria for each class are shown in this table, along with what recommendations you would give. So here's another excellent spot to hit pause. So you can assess of asthma control in patients 12 years and older and the recommended action for treatment. Leading us to drugs for acute exacerbations. Acute severe exacerbations of asthma require immediate attention. The goals are to relieve airway obstruction and hypoxemia and normalize lung function as quickly as possible. Initial therapy consists of the following: give oxygen to relieve hypoxemia, give systemic glucocorticoids to reduce airway inflammation, give a nebulized high-dose SABA to relieve airflow obstruction, and then last, giving nebulized ipratropium to reduce airflow obstruction. Severe cases may benefit from IV magnesium sulfate or inhalation of a heliox. After the resolution of the crisis and hospital discharge, an oral glucocorticoid is taken for 5 to 10 days. All patients should also take a medium-dose inhaled glucocorticoid. Full recovery of lung function may take weeks. So drugs for exercise-induced bronchospasms. Exercise increases airway obstruction in practically all people with chronic asthma. The cause is bronchospasm secondary to the loss of heat or water from the lung. EIB usually starts either during or immediately after exercise, peaks in 5 to 10 minutes, and resolves 20 to 30 minutes later. With proper medication, most people with asthma can be as active as they wish. Indeed, many world-class athletes have asthma. So to prevent exercise-induced bronchospasms, patients can take a SABA or cromolyn prophylactically. Inhaled SABAs, which prevent EIBs, is more than 80% of patients, are generally preferred over cromolyn, which is less effective. A beta-2 agonist should be inhaled immediately before exercise, whereas cromolyn should be inhaled about 15 minutes prior. So, the reduction of exposure to allergens and triggers. Common sense tells us that for patients with chronic asthma, the treatment plan should include measures to control the allergens and other factors that can cause that airway inflammation and exacerbate symptoms. Important sources of asthma-associated allergens include that house dust mite, warm-blooded pets, cockroaches, and mold. Factors that can exacerbate asthma does include tobacco smoke, wood smoke, and household sprays. To the extent possible, exposure to these factors should be reduced or straight up eliminated. Bringing us to the management of COPD. The diagnosis and treatment of COPD is addressed in the Global Strategy for the Diagnosis, Management, and Prevention of COPD. These evidence-based guidelines, developed by the Global Initiative, were updated last in 2016 and can be seen here at the goldcopd.org. So, measuring lung function. Patients who have signs and symptoms of COPD, such as dyspnea that has worsened over time, a chronic cough, sputum production, and a history of smoking tobacco and or other risk factors, should be tested with a spirometer to measure the degree of airway obstruction. Your post-bronchodilator FEV1 over FVC of less than 0.7 is needed to confirm a COPD diagnosis. The classification of airway limitation severity. Severity of airflow limitation is based on spirometry. The four classes of increased severity are mild, moderate, severe, and very severe. Again, remember that all patients' a diagnosis of COPD requires that FEV over FVC of less than 0.7% or 0.7. So there are four different levels. Greater than 80% predicted, 50% greater but less than 80, 30% greater but less than 50, and then less than 30% to see the different severity levels. Our treatment goal. There are two primary goals for COPD management. The first is to reduce symptoms, then improve the patient's health status, and then increase exercise tolerance. The second goal is to reduce risk and mortality. The latter is accomplished by preventing COPD progression and by preventing and managing exacerbations. So treatment goals are based on the overall level of the COPD severity. Again, looking at the GOLD guidelines that classify COPD severity from A through D, and the considerations of the patient's symptoms, their airflow limitation severity, the risk level for COPD exacerbation, and any kind of comorbid conditions they may have. Symptoms are quantified using the instruments on the COPD assessment tool and COPD control questionnaire. For the full instructions determining severity, take a look at the websites. They are up. The management and prevention of COPD. Again, that goldcopd.org. So again, your groups A through D will tell you whether they are mild, moderate, to severe, or very severe. The management of stable chronic obstructive disease. Pharmacologic management of stable COPD relies primarily on bronchodilators, your glucocorticoids, and your phosphodiesterase type 4 inhibitors. The GOLD guideline offers recommendations for each, starting off with bronchodilators. Inhaled long-acting formulations of either a beta-2 agonist or anticholinergics are preferred for bronchodilation. Theophylline is reserved for the use only when other bronchodilators are no longer available. Your glucocorticoids. Long-term inhaled glucocorticoids are recommended when symptoms are severe or when long-acting bronchodilation are inadequate for the management of exacerbations. When given for COPD, Glucocorticoids should be given in a combination with a LABA. Glucocorticoid monotherapy is no longer recommended for the long-term therapy because, again, it has a decreased efficacy when used alone. Bringing us to the phosphodiesterase type 4 inhibitors. In patients with severe chronic COPD, the risk for an exacerbation may be reduced with roflumilast. Roflumilast is a selective inhibitor of the PDE, an enzyme that inactivates cyclic adenosine monophosphate. The drug reduces inflammation, cough, and excessive mucus production by raising levels of cAMP in lung cells. Adverse effects, however, can include diarrhea, loss of appetite, weight loss, nausea, headache, back pain, insomnia, and depression. Safety in pregnancy has not been established. The dosage is about 500 micrograms once daily, taken with or without food. Roflumilast should be used in a combination with tiotropium, a LABA, or an other inhaled glucocorticoid. The management of chronic COPD. Exacerbations. Although some of the same drugs used for the management of stable COPD are also used for the management of an exacerbation, the drug formulations used, however, differ. For example, although LABAs are preferred for a stable COPD management, SABAs are preferred for the bronchodilation during an exacerbation. Furthermore, systemic glucocorticoids greatly improve outcomes when used in the management of a COPD exacerbation. Other agents that may be used to control and shorten exacerbations include antibiotics for patients who have signs and symptoms of infection and supplemental oxygen to maintain an oxygen saturation of 88 to 92. So, prescribing and monitoring considerations. When it's a glucocorticoid, when it's inhaled, there is the list we've spoken about, the beclomethasone, budesonide, cyclosinide, flunisolide, fluticasone, and mometasone. And orals, methylprednisolone, prednisolone, and prednisone. The nursing implications summarized in the following discussion refer specifically to the use of glucocorticoids again in asthma. A full summary of nursing implications again for glucocorticoids are discussed in Chapter 56. The pre-administration assessment, the therapeutic goal. Glucocorticoids are used on a fixed schedule to suppress inflammation. They're not used to abort an ongoing attack. The baseline data determine FEV and the frequency of severity of attacks and attempt to identify any kind of triggering factors. Identifying the high-risk patients. Again, you inhale glucocorticoids. Those preparations are contraindicated for patients with a persistently positive sputum culture for Candida albicans. Oral glucocorticoids. These preparations are contraindicated for patients with systemic fungal infections and for individuals receiving a live virus vaccine. Use with caution in pediatric patients and with women who are pregnant or breastfeeding. Also exercise caution in patients with hypertension, heart failure, renal impairment, esophagitis, gastritis, peptic ulcer disease, myasthenia gravis, diabetes, osteoporosis, or infections that are resistant to treatment and in patients receiving a potassium-depleting diuretic, digitalis glycosides, insulin, oral hypoglycemics, or NSAIDs. The administration consideration. Again, you want to consider those routes. Inhalation. The inhaled glucocorticoids are administered with an MDI, a DPI, or a nebulizer. Oral. Alternative day therapy is recommended to minimize adrenal suppression. Again, during long-term treatment, supplemental doses must be given at times of severe stress. Ongoing monitoring and intervention. You're evaluating therapeutic effects. Providing should monitor status of patients with asthma at each appointment. That monitoring should include tracking that PEF, symptom frequency, and symptom intensity. Again, that nighttime awakening effect on normal activity, and the SABA use. How often are you using it? When are you using it? What triggered the attack? Minimizing adverse effects. The inhaled glucocorticoids. If candidiasis develops, it can be treated with an antifungal medication. Also, using a spacer will decrease deposits onto the oropharynx, thereby decreasing the risk of this condition. Your oral glucocorticoids. Prolonged therapy can cause serious adverse effects, including osteoporosis, hyperglycemia, peptic ulcer disease, and growth suppression. These effects can be reduced with an alternate day dosing. Additional intervention that apply to adverse effects of long-term glucocorticoid therapy are summarized in Chapter 56. The big one, though, is the adrenal suppression, which is a potentially life-threatening adverse effect on long-term glucocorticoid use. When discontinuing a systemic glucocorticoid, you must be sure to do it gradually to allow the body to resume producing the endogenous hormone. Again, during times of severe physical stress, where the body would normally produce high levels of glucocorticoids, it's essential to increase the dose of a systemic glucocorticoid. Which brings us to the beta 2 adrenergic agonists. Again, the things that we want to consider. Inhaled, short acting. So we got your albuterol, your levobuterol. Then your long acting, your formoterol, indacaterol, olodaterol, and salmeterol. And then you got your oral options, albuterol and terbutaline. So your pre-administration assessment probably is somewhat similar. Your therapeutic goal is a short-acting inhaled beta-2 agonist, which is used as needed for prophylaxis of an exercise-induced bronchospasm and to relieve any kind of ongoing asthma attacks or COPD exacerbations. Oral and inhaled LABAs are used for the maintenance therapy. Your baseline data should determine your FEV1 and the frequency and severity of attacks, and attempt to identify again the trigger factors. Monitor home assessment of PEF at each clinic encounter. Identifying the high-risk patients. It's important when the systemic beta-2 agonists are contraindicated for patients with a tachydysrhythmia or tachycardia, especially associated with digitalis toxicity. The use of a systemic beta-2 agonist with caution in patients with diabetes, hyperthyroidism, your organic heart disease, hypertension, and angina. The administration consideration again for a beta-2 agonist is that you're administering it with an MDI, DPI, or nebulizer. Some pharmaceutical companies also have developed specialized inhalers devices for their products, so spacers. Instructions for use with return demonstration by the patient should be undertaken when you are prescribing this medication, and to periodically to verify that the proper technique is being used. Ongoing monitoring and interventions. Evaluating therapeutic effects. Your asthma control should be assessed at each clinical encounter, monitoring the PEF, symptom frequency, and symptom intensity. Nighttime awakenings, effect on normal activity and SABA use. It is also important to discuss medication adherence or any kind of deviation from the management plan, because patients may forget some of the finer points of an inhaled medication administration. This is a good time to have that patient demonstrate their technique for using that inhaler. You also want to, make sure that you're minimizing any kind of adverse effects. And it's an inhaled short acting. When used at recommended doses, SABAs are generally devoid of significant adverse effects, but cardiac stimulation and tremors are most likely with systemic therapy. Whereas your long-term acting beta agonists, when used correctly, LABAs are perfectly safe. But again, when used alone for prophylaxis, they may increase the risk for severe asthma attacks and asthma-related death, which is why they're not recommended that way. To minimize that risk, these drugs should always be combined with an inhaled glucocorticoid. And preferably, you use a combo inhaler, so it's all in one device. Oral beta agonists. Excessive dosing can activate a beta 1 receptor on the heart, resulting in anginal pain and tachydysrhythmias. For that reason, selective beta 2 adrenergic agonists should be prescribed rather than the non-selective beta adrenergic drug. A tremor is common with systemic beta 2 agonists and usually does subside with continued drug use. If necessary, tremors can be reduced by lowering the dosage. Speaking strictly to cromolyn, your pre-administration assessment, the therapeutic goal. Cromolyn is used for acute and long-term prophylaxis of asthma. The drug will not, however, work to abort an ongoing asthma attack. Your baseline data should determine FEV1 and the frequency and severity of attacks and attempt to identify any kind of trigger factors. Identifying the high-risk patient, cromolyn again is contraindicated for the rare patient who has experienced allergic responses to cromolyn in the past, which again should be common sense. If you're allergic to it, don't use it. The administration consideration of cromolyn is administered with a nebulizer. Your acute prophylaxis, when administered 15 minutes before exercise or prior to exposure to other precipitating factors, cromolyn can prevent an asthma attack. Your long-term prophylaxis, when taken on a regular schedule, cromolyn provides long-term prophylaxis for asthma. The full therapeutic effects may take again several weeks, however, to develop properly. Ongoing monitoring and interventions. Evaluating therapeutic effects, the monitoring of PVF, symptoms, frequency, and symptom intensity, your nighttime awakening, effect on normal activity, and the requirement for SABA use at each clinical encounter. Minimizing adverse effects. Again, cromolyn is devoid of significant adverse effects and drug interaction. So if you're having an allergic reaction, don't use it. Otherwise, your side effects are relatively minimal. Speaking of theophylline, though, that is the one where your pre-administration assessment and therapeutic goal as a bronchodilator taken on a regular schedule to decrease intensity and frequency of moderate to severe asthma attacks. Again, this is the more dangerous one. You want to determine the FEV and the frequency and severity of attacks. Your theophylline is contraindicated for patients with untreated seizure disorders or patients with peptic ulcer disease. You use it with caution in patients with any kind of heart disease, liver disease, kidney dysfunction, and even if it's severe hypertension, because they exacerbate and can cause further damage. Your administration consideration, whether it's oral or IV, again, your oral dosage is individualized. Doses are low because there is a very narrow window for toxicity. Doses are low initially and then increase gradually. The dosing objective is to produce plasma theophylline levels in a therapeutic range. Again, that range is 5 to 15 micrograms. In IV, the dosage is again individualized, administered slowly, and you need to definitely verify your compatibility with other IV drugs before mixing it. Ongoing monitoring and intervention. The evaluating therapeutic effects. You want to monitor theophylline levels to ensure that they are the therapeutic range, again at 5 to 15 micrograms per ml for most patients. Minimizing adverse effects. The big ones again are nausea, vomiting, diarrhea, insomnia, restlessness that develop when plasma levels rise above the 20 microgram level. But the severe ones, convulsions, VFib, occur when the drug level is above 30 micrograms. So your dosage should be adjusted to keep the theophylline level below 20 micrograms. And then minimizing adverse interactions. Your caffeine can intensify the adverse effects of theophylline on the heart and CNS and can decrease theophylline metabolism. Smoking and tobacco use, tobacco or marijuana use rather, can increase clearance to 50% in adults and up to 80% in older adults. So your secondhand smoke also increases theophylline clearance. Accordingly, it's important to inquire whether there's any kind of smoke-related habit in the house so that you can properly dose the patient. And then drugs that reduce theophylline levels, your phenobarbital, your phenytoin, rivampin, and other drugs that lower theophylline levels. In the presence of these drugs, the dosage of theophylline may be needed to be increased to stay therapeutic. Then other drugs that increase theophylline levels include your antibiotics and other drugs that can elevate theophylline levels, your cimetidine, fluoroquinolone antibiotics. When combined with these drugs, theophylline should be used in reduced dosages. So finally, the management of your toxicity. Your theophylline overdose can cause severe dysrhythmias and convulsions. Death from cardiorespiratory collapse may occur. Manage toxicity by discontinuing theophylline and administering activated charcoal, plus a cathartic. Give lidocaine to control ventricular dysrhythmias and IV diazepam to control seizures. That concludes our chapter. So I thank you all for listening and watching, and I'll see you at the next chapter. Till then, thank you and goodbye.